considerations. So, one thing we know about the human vasculature is that it is the highway by which we get our job done. We have beaten this death in several other chapters. I think it's like chapters 5 and 6 in Embalming 1, which just talk primarily about memorizing the arteries and why we use them and whatnot. Any change to this obviously is going to cause a problem, whether it be an interruption as a result of a clot, whether it be obstructions as a result of disease, or just because age happens. And obviously there's a lot of drugs on the market that totally mess up your vasculature. So there's 3 layers. You have the tunica intima, which is the inner lining. It's endothelial cells. They form the walls, the capillaries, inner walls of veins and arteries, and it covers everywhere. So even capillaries have the intima. The media, which is the muscle layer basically in elastic tissue, and the adventitia, the tunica adventitia. The outer layer, mostly connective tissue. And people always, for whatever reasons, forget that the lumen is actually a structure of an artery and a vein. The hole in the middle matters. When you're getting a multiple choice question that says which of the following are structures of an artery or a structure of a vein, do not forget to actually indicate the hole. Intravascular problems can result in breaks or tears. They can be small, petechiae, something like that, or they can be huge, aneurysms, where the fluid just flows out of it. Most common problems are sclerosis, scarring of the arteries, and coagula. And this list here is just beautiful. I would, without a doubt, note card this, Quizlet this, and make something happen with it because it is just so important and it tells you so much. Pre-injection should not be used if you feel at any point you're going to have difficulty with distribution. The reason being is you're going to cause swelling. Okay, you're going to cause swelling. Persons who've had vascular diseases may have been put on anticoagulants, which hallelujah if they are, because it makes drainage so much easier for us. Anyone over 30 can exhibit arteriosclerosis. You're going to have some type of scarring. And people within their mid-50s can die of this disease. And if you even think for a second this might happen, just go right for the carotids. Forget about anything below the waist. You have 3 types of arteriosclerosis. In type 1, you can see the hole in the middle is quite well defined. It's basically the walls have hardened a little bit. And you can still use this for arterial injection. And notice it says that if you're in an autopsied body and they have a common iliac, this is basically what you're going to be feeling, type 1. Type 2, we can see that the white area is much more closed. It's pushed to one side. The artery's been filling up. We can use an arterial tube that fits, but generally not one the same size as we normally would use the artery. In type 3, it's basically completely occluded, like 99%. It does talk about canalization, which is, as you can see, the little thing that's pulled out here has all sorts of little white dots. You're not going to be able to fit an arterial tube in there, and that's what you take away from this. You're going to have gangrene with this. You're going to have all sorts of circulatory problems. So in the presence of sclerosis, the strength of the arterial solution can be increased if distribution is poor or slow. Fancy way of saying you're going to jack the index so that what does get through will actually get the job done. You definitely want to use dyes as tracers. Allow gravity to, because you're going to look for any tool you possibly can to help you out at this point. Start with a very slow rate of flow, and once distribution is established, you can increase the rate of flow. Notice this says nothing about pressure. So you can actually use a very high amount of pressure, which is, again, not recommended here, okay? It's the way I kind of do things, and it works for me, but it is what it is. But you can injection pressures with a low rate of flow and then build into things once you've actually succeeded in establishing routes. Multi-site should be used. If you're doing multi-site, you can actually use higher pressures to push through things, but be judicious about that. That doesn't mean going guns blazing. It says just enough to establish your local distribution and get the job done, and then you can reduce your rate of flow. If you do have to use the femoral for some reason, don't cut into it where you actually feel a piece of stone, because you're wasting your time with it. And it gives you the definition of an atheroma. Make the incision a little larger than normal in the soft area of the femoral so that you have actual space to operate, because you don't want to raise it up. You don't want to use very thin ligature. You don't want to saw through the artery by accident. So definitely be very careful. Do not monkey with these too often, because if they break, you're going to have good times. It even says use a hemostat. You know, clamp it down on a the end closest to your incision so that it holds onto it or something. Shows you areas, common sites of arteriosclerosis. You can see it's all in the fun area of the external iliacs and femorals, and then even right before the knee, where it turns into the anterior and posterior tibials. Surgical repair of an aortic aneurysm is going to cause extreme facial swelling. Typically, femorals would be good for this. If you didn't have the sclerosis, because you could just basically shoot up, isolate the head, etc. Strong solution, use of dyes, tracers, slow rate of flow, anything to kind of not make your life miserable. Okay? If the drainage is established, continue to inject. If you're getting no drainage and you just see the abdomen swelling, you might as well stop because it's just flowing into the guts. Multi-point time. And then you're going to be doing the usual abdominal preservation through, embalming the flaps of the body. So even if it's unautopsied, remember, you might have to get the hypovalve trocar and treat the walls of the abdomen, the flesh of that lower body with your hypovalve trocar in the event of something like this. If you can actually get to the actual site where the hole is, use the hole to your advantage. It's the aorta. You couldn't want for too much more. Valvular diseases in the heart. One heart valve fails, don't care. But when most of them fail, you have huge problems. And that's the issue. So it talks about the different heart valves. Please go ahead and look at these and what they do. I give you plenty of diagrams, whether they're tricuspid or bicuspid. All of this is fair game, and some of this should be a regurgitation from your anatomy class. Valves can be affected by the same degenerative and pathological conditions that affect the arteries. If it's something being carried in the blood, obviously the heart is going to be infected by it as well. Obviously, miracles of modern medicine, things take longer, but we still have problems with our hearts. 1 in every 2 deaths is attributable to cardiovascular disease. About what happens when the valves are damaged or fail. Understand, it's got sections of the heart to begin with, push itself through pulmonary circulation, and then when it finally gets stuck, it's going to cause purge from the lungs. You can see it gives you basically the nitty-gritty for all of that. It does say, by squeezing up the contents of the hollow portions of the lung through the trachea, understand that is not blood. That is the stuff that's usually in the lungs, the mucus, the pneumonia fluid, the stuff like that. We're going to get that with the trocar eventually anyways. Congestive heart failure, one of the biggest problems we run into these days. We see the veins are engorged in the neck. Facial tissues are dark because the cyanotic fluid is building up into the head. Fingers are cyanotic. Pitting edemas. Blood is more viscous. You can see that this is just a mess, an absolute mess. And it says carotid and jugular combo is best restricted cervical to help clear this out. First gallon should be a mild solution to clear blood congestion, discoloration, which, yeah, you want to get that blood out of there because if you inject it with something higher, you run an increased risk of formaldehyde gray. If edema is present, then you can inject a stronger solution later to help pull the fluid out once you've gotten rid of the blood without that discoloration problem. Toxicities, pushing it down on the inferior vena cava to diminish drainage from lower areas. You can get your trocar in there and take care of that, and it tells you how to do it. And be very careful when you see something like this slide right here. Begin injection at a high enough pressure and rapid enough rate of flow to establish good distribution. What that is not saying is going in there guns blazing. It does not say nuke them. It says inject at enough to get the job done, which might mean regular pressures, might mean a little bit higher, but don't just turn the thing all the way to the right and watch the machine explode on you. Be judicious, and when in doubt, higher pressures with lower rates of flow will probably go best for you because the rate of flow is what's going to dislodge and cause problems. And for anything like this, continuous drainage should be used and adjust pressures and rate of flow as the embalming progresses. Liver may be enlarged in congestive heart failure. Its function will be decreased. That means problems with buildup of waste in the body. Pulmonary edema, lung purge, obviously, just let it do its thing, and when you're done, pack it. That's kind of the way that works. Aspirate bodies with congestive heart failure immediately. This is the exception to the 8-hour rule. So you should make a column for exceptions. It's important because we want to get as much of the swelling away from the head as possible. And by keeping pressure in the system, that is not conducive to that type of. Talks about vasodilation and vasoconstriction. It says when you're injecting and you see that one side of the body received a large amount of solution, the other one small, usually a result of a stroke, a cerebrovascular accident. Understand, this is usually something very visible. I mean, you see left half is white, red is on the other. And if that happens, and it gives you the reason why that happens right here, you're multi-pointing it. There's really no way around it except to go around it. Coagula, well, if it stays in the system, if the blood stays in the body, which it does, and we see that like up to 85% exists in the capillaries, it's going to congeal. And when that happens, it starts to stick together and get nasty, messy. So if we're using things like the femoral as an injection point and pushing towards the feet, we run the risk of blocking something towards the leg. If we turn it and go the other way, we risk isolating the head. And vice versa. If we start up at the neck and we push down, we run the risk of blocking everything below a certain point. So it is kind of what it is. Begin embalming at a slower rate of flow and no pre-injection so that fluid passes over coagula, does not push it. Those of you that have me in lab or had me in lab know that that is the way I embalm. Higher rates of pressure with low rates of flow until I establish distribution, and then I just wait the body out. We don't care so much about venous coagula because on the venous side, the pipes do nothing but get bigger. So as the veins get closer towards the heart, they get larger. That means the little coagula or the bigger coagula are going to come towards the hole. No matter what anyone tells you, no matter what you believe, when it comes to drain tubes versus angular spring forceps are the only type of drainage instrument that can actually grab and pull. Intermittent drainage is preferred. So we build up pressure, it pushes stuff up towards us so that when we open it back up, it comes out. Well, Professor Finn, what are some ways we can do that? Simple. Stick your finger in the hole of the artery and block it. Close the angular spring forceps, hold it down with your fingers over it, and it will build up some pressure. When the condition is encountered in a localized area, it is a stronger arterial solution to ensure that a minimum amount of arterial fluid delivers maximum preservation. We've seen this throughout this chapter and even the last one. Sometimes when you're dealing with not a lot of opportunity to get stuff done, you use a higher index and a higher amount of solution, higher concentration, I should say, so that whatever does gets its job done. Diabetes, crap, man. That is like distribution nightmares. So diabetics are very prone to sclerosis, poor peripheral circulation. It's why they're usually missing limbs, and we need to be concerned with that. Also, the bacterial and fungal infections require us to use a fluid appropriate for it, generally strong preservative, 25 index, high index or better, or even a specialty fluid for diabetes. It says first gallon can be slightly milder than subsequent injections. Some embalmers prefer to use a co-injection fluid to assist in clearing of discolorations. Hey, you do whatever it is that you learned and you were trained on. Generally, though, with diabetes and you have sclerosis, restricted cervical is highly suggested. Isolate the head, treat the body, then treat the head. If you're going to use massage, do not massage the death out of the body. Be very careful with it because you have circulatory issues, and by squeezing, you run the risk of dislodging something you didn't want to dislodge. Because of all the stuff in the system, diabetics may also have an unideal, non-ideal pH value in their body. And since we already know that embalming solutions work best in a slightly alkaline environment, we might need to do some co-injections to help with that. So buffers, for instance, might be something that we add. Then you add in the fact that typically diabetics may be clinically obese, larger amounts of solution, not necessarily stronger index just because a person is obese. Definitely hit them with the cavity fluid because fungal infection is commonly found. 15 ounces should be used for each major body cavity. If we translate that, that is one bottle for every major body cavity. Mycosis and gangrene are not going to be treated by arterial injections, so we have to break out the hypovalve trocar, the infant trocar. Hypodermic injection might be necessary. And Definitely we'll probably want to cover some of this stuff up because it smells amazing, and you don't want stuff to smell amazing being smelled in your visitation room. Might even have to deal with ulcers. So review treatment for bed sores. We're also going to beat that into you. If you haven't taken restorative art already, you should know how to treat that. If emaciation happens, well, tissue building comes into play. So extravascular resistance. We know that not all resistance is bad, okay? But if you do get some extravascular resistance, you definitely want to get a slightly stronger arterial solution. Again, don't go in guns blazing, but if you're going to use like, an 18 index, you might want to kick it up to a 22 index or something like that. Multi-site might be a problem. Go around so that you get something done. Higher pressures can be used to assist distribution. I am a big fan of that. Alternate drainage is recommended when not using concurrent drainage. So it's flowing, stop it, inject, turn it off, open it back up, that sort of thing. Alternate, member, between alternate and intermittent, what the differences are. Review the extravascular resistances. Many of these have been talked about with their solutions in previous chapters, so I'm not going to destroy that in the lecture right now. Okay? And that's it. We'll see you next week, and we will give you a test.